Now coming to myopia control glasses, that is also a recent development, relatively we have much more data on atropine. There are several products mentioned in this talk, but I have no financial disclosure or any financial relationship with any of them. So even though myopia is increasing, if you look at the global myopia control uptake, it is 90% of them still use single vision glasses, and only around 1 to 3% are using myopia control solution of any sorts, not leave alone glasses. So I think this number needs to change as we go further. So looking at again myopia control options, if you look only at optical options, there is ortho K, there is orthokeratology specialty multifocal soft lenses, there are multifocal and spectacles and bifocal spectacles. So these are the optical interventions which are available for us. Bifocal glasses, peripheral defocus glasses, multifocal contact lenses, dual defocus contact lenses, and orthokeratology. I'm only discussing those, there are more than these, but I'm only discussing which we have it available here for us to use. So if you look at bifocals and progressive addition lenses, myopia is also sometimes associated with higher lag of accommodation, which creates a hyperopic defocus, which in turn acts a cue for axial elongation. And children who have progressive myopia with high lag of accommodation, probably a small subset of children may do better with bifocals. Children who have esophoria for near, also you may look at adding a bifocal component as a myopia control measure. So bifocal glasses do work, but in a smaller subset of patients with these two caveats. Multifocal designs now are in vogue, and there are now several products available in this. So what do they believe in this is, when you give a single vision glass, the central rays, because of the shape of the eye, central rays do get focused on the retina as intended, but peripheral rays go behind and produce a hyperopic defocus, and that is a cue for elongation as suggested earlier. To accommodate these rays which are peripheral and which are going behind the retina, eye elongates to accommodate them. So if you can produce a peripheral zone of defocus to make these peripheral rays artificially myopic, you can have good vision and take away this cue for elongation of the eye. And this is the principle behind coming up with several multiple segment glasses, multifocal glasses, which we are going to see. So first one of the block was MyoSmart, which was by Hoya, and it uses a technology called defocus incorporated multiple focal segments. Basically these are lenses which are there is a central 9mm optical zone, and then there is a 33mm zone of lenslets around which are surrounding the 33mm of the central zone, and they all produce 3.5 diopter myopic defocus. So each at 1mm, each of these lenses produce a plus 3.5 or are actually plus lenses, so that they produce a myopic defocus for the peripheral rays, and that's supposed to control the elongation of the eye as well as the myopia. So first study which came out with Lam et al., who were responsible for designing this lens, and they showed that myopia progression was 0.41 at 2 years and 0.052 at the end of 3 years, which counts to around 60% efficacy in controlling the axial length. If you remember, my atropine does not correlate very well, or is not very effective in axial length elongation, preventing axial length elongation, but these glasses seem to are better in axial growth or axial elongation. And compliance was supposed to be good, adaptation to the peripheral blur was very clear, and 70% of the children progress less than 0.25. So this is the first study which came out with DIMS lenses. What is our experience with DIMS? We enrolled around 108 eyes of 54 children, mean age was 11.2 years, and 6 months after starting DIM, the average progression of spherical equivalent reduced to 0.20, and at the end of 1 year, if you do it cumulatively, progression of myopia was less than 0.5, that is around 0.35 diopters. So if you look at it, before starting it was 0.98, and when we looked at it at 6 months it was 0.20, but which increased slightly to 0.35 over a year. Similarly, axial length increase, which was happening at the rate of 0.37, dropped to 0.07, and then slightly ticked up again here, 0.23. So this is our data, not yet published, but this is Shankar Nethralaya data with using DIMS, because I have the data only for DIMS because that was the first company which made it available in India. So on an average 59% reduction in myopia progression in 6 months, and 57 if look at 1 year, it looks comes down to around 57%. How does it compare against atropine? So in short term study it looks like DIMS lenses work better than low dose atropine. This is the retrospective data from this study, and you can see axial length elongation was significantly lower in DIMS lens group. Then the second thing which was come into the market was HALT technology by Essilor. It has a spherical front surface with 11 concentric ring formed by contiguous highly aspheric lenslets of 1.1 millimeter diameter. Again, central zone, optical zone is around 9 millimeters, and geometry of the spherical the aspheric lenslet has been calculated to generate a volume of myopic defocus. So it does not have a single point of defocus, but it produces a volume of defocus across the entire posterior pole because of the except for the central 9 millimeter zone. Comparison of DIMS and HALT, only one study by Guo et al. And again in this HALT seemed to perform slightly better than DIMS, again with only a 6 months data which is available. The last or the most newest product is by Care Technology using Zeiss. Here again defocus is produced by incorporation of cylindrical annular refractive elements. Two different available options are available aimed at younger and older children. There is a central optical zone which is surrounded by alternative rings of correction and defocus. Myocare S and Myocare both are available. Myocare S is slightly more expensive, but efficacy is being reported in the RO posters which they have presented around 50 to 60% comparable to other two products. The new kid on the town is going to be diffusion optic technology lenses or dot lenses, where there are translucent dots incorporated in glasses. They reduce contrast at the retina, and low contrast is equivalent to stimulating the natural outdoors. This technology does not produce a defocus at the retina, but it modulates on and off pathways at retina using a low contrast stimulus which is produced. There is a 4-year data available, not yet available in India, and effective in both younger and older children, and compared to single vision glasses, dot perform better in this study which has been published in 2023. So what do these myopia control glasses bring to the table? They are safe, they are on the face, so you don't have to worry about putting the drop every day. They are effective, 55 to 60% irrespective of which product you are using. Better control of axial length elongation compared to atropine. Mechanism of action is at least postulated mechanism, makes sense, and it is non-interventional, nothing is going into the eye per se. Concerns, cost and reduced effectivity over a period of time. It has not, there is a kind of a in our small data also you can see that there is a really good reduction in 6 months, and then slightly there is upward bump. So probably if you follow them for a longer period, you may have a decrease in effectivity. Although 6-year data is out and they have not reported any major decrease in effectivity, but there is a little bit of concern there. Cost, now my question is it really a concern? So lifetime cost of traditional myopia management, which is single vision glasses, was definitely more than myopia control glasses or LDA. This is a complex cost effectiveness analysis done, published in BJO. I've get the reference here. Those who are interested can read it. So it was $7,437 versus $7,280. This lifetime cost analysis was done in 2 countries, Hong Kong and Australia, and it was definitely much lower for atropine, but it was comparable to single vision glasses and myopia control glasses. So if you are concerned about patient not affording it, maybe you can use this statistics to help them to confirm. There is another study with Agium. Again, they also looked at good cost effectiveness, and again outdoor activities scored very well on this. Orthokeratology lenses and Hall lenses also worked well. So when patient says, why should I buy these 18,000 glasses, you have to explain that this child is going to need these 18,000 glasses for probably 5-6 years, but benefits are going to last them for lifetime. Do I have time for contact lenses? Yes. Otherwise I can stop here.
Yes, ma'am, we have time.
Because thing was only myopia control glasses. But so okay, soft contact lenses and orthokeratology both are specialty contact lenses designed for myopia control. So the only multifocal soft contact lens which has been FDA approved is this MySight or dual zone lenses, which has again a defocus zone, a correction zone in the center, and myopic defocus in periphery. Expensive and not available yet in India. So effective, this is not done in India. This is a company produced, this is a study by Chamberlain et al., and you can see 109 children which were randomized to MySight and single vision lenses, and mean myopic progression in the treatment group was 0.51 compared to the people who wore single vision lenses. So again 59 to 60% reduction in refraction, 52% reduction in axial length elongation. Seed lenses are a extended depth of focus design. Initial trials are promising. More trials are ongoing. In fact, LVP has just published in last year. I should have put that here, but they have again looked at Indian population with seed lenses and good reduction in myopia progression using seed lenses. Orthokeratology, new kid on the block, in the sense it has been on the block for many years, but has probably gained traction again because of availability of better lenses. Previous designs were really not that great, and these are reverse geometry lenses which are designed for overnight wear. They temporarily flatten the cornea when worn overnight, and again it works on reducing the peripheral hyperopic defocus by making a zone of myopic defocus in the periphery. One advantage is it produces a spectacle free, you can be spectacle free up to a certain, say, -6 diopters during daytime, and also works on very good on myopia control. So it not only eliminates daytime spectacle wear, but can also work on slowing axial length elongation. Central corneal flattening is also associated with relative peripheral myopic shift, more effective in younger children and rapid progressors and high myopes. Microbial keratitis definitely in our country definitely remains a concern, needs an optometrist or a doctor who knows how to fit these lenses properly, because fit is very important and you need a little advanced knowledge to fit these lenses. But very good myopia control in randomized control trials, and among everything probably the best axial length control was achieved with ortho lenses. So these are the various ortho lenses which are available in India, and you can definitely look at in the patients who are interested, especially those children who pursue sports, who are in professional sports. Ortho is a good option. Ortho lenses which were available a decade back probably were not that great, but now I think it's a viable option in a certain, again expensive, but so what are the risks which are across board with all the myopia control strategies? We don't know rebound. In fact, now atropine rebound, we already have Atlas study which I quoted, that rebound definitely happens. Ortho lenses are known to accelerate progression, in fact not just rebound but really accelerated progression, and of course infiltrates and infectious choroiditis is definitely a primary concern. So if you look at the safety, spectacles are relatively safe, no adverse effect. Contact lens wear, safety concerns, fit concerns, patient education is very important. Patient selection is even more important. Please don't select just because you have option available. Select the patients who are progressing and who really need the intervention. Not every child progresses. Don't miss children with syndromes, subluxated lenses and keratoconus and put them on atropine. Atropine does not work on astigmats and hyperopia, so don't put every child who needs glasses on atropine. So where do we go? As I said, every diopter of control improves quality of life later in life. We should move from progressive single vision glasses to managing myopia, or myopia progression rather. Increase options which are there now to choose in coming years and which is going to increase further. It's a fast changing field with newer strategies, and now we have not just one option but a combination of options which can be, and we should need to be updated and follow evidence based practice. Thank you for your attention.
So, thank you, madam, especially for your this talk on myopia control glasses, for which everybody will be having doubts. Probably you can have your doubts personally discussed with madam after this session, since we are running just on time, and so we don't want to create any lack. So, thanks to Sumitha madam, our guest speaker, and to my fellow speakers, Dr. Rishmi and Dr. Chaitanya.